Yes.
Good morning. Good morning, everyone. Shalva Ganesh will be presenting the case and will be moderated by Professor Harjeet Singh and Professor Sadaf Ali. And Professor Vaibhav will be joining us shortly. Now it's all yours, Sadaf and Harjeet. You can take over now.
Yeah, we can start directly with presentation.
Shalva Ganesh, you can go ahead.
You
Good morning.
please start, Dr. Ganesh.
Yes. Morning, ma'am. My patient, 32-year-old female, teacher by occupation, resident of Jharkhand, concerned with chief complaints of loose foods since 15 years, ma'am. History of present illness. She was apparently all right about 15 years back when she had increased frequency of stools about 5 to 10 times per day and small quantity and liquid stools and not cold smelling, occasionally mixed with blood, with history of increase in frequency to 15 to 60 times per day since last 5 years. She also gives complaints of mucoid discharge per rectum since 3 years. And history of urgency and incontinence present, including maternal incontinence, since last 1.5 years. And she complains of loss of appetite, easy fatigability, and loss of weight about 16 kg in the last 6 months. And history of passing blackish, cold smelling stools 1 to 2 days, occasionally in last 1 year. She also complains of pain in abdomen in periumbilical region, colicky pain, intermittent while passing stools, non-radiating type, and not related to this. And there is no history of tenesmus or pain during defecation, or vomiting or abdominal distension, fever, stress, mass per abdomen, or palpable swelling elsewhere, or no history of dizziness, syncope, breathlessness, or blood transfusion in the past. And I would like to ask skin lesions and joint pain and fluid redness of the eye.
Your voice is quite breaking, sort of. Can somebody correct it? You continue. Go ahead. Go ahead.
Yes, ma'am. History of admission to the hospital and resuscitation with IV fluids present multiple times in the last 1 year with no other imaging or intervention in the past. Past history, no case of anxiety disorder on medication, and no history of any other comorbidities, and no history of previous surgeries. And family history, no history of any malignancies or TB in family. She has 1 child. And menstrual history, she had regular menstrual cycles and normal flow. Personal history, she is having mixed diet, the appetite is reduced, and sleep is disturbed occasionally due to bowel movements at night. And bladder habits, normal and regular. And I would like to ask her how she's regularly going to work or not, because that loose stools will how impact the quality of life, because she's a teacher by occupation.
Yeah, Dr. Salwa. So what all things you would, yes, just summarize it first.
Yes, ma'am. 32-year-old teacher presented with loose stools mixed with blood for the past 15 years, and the history of mucous discharge in 3 years with loss of appetite and significant loss of weight for the 6 months.
Okay. So, what all things you understand that you would like to know from history which is not provided to you? Anything that is missing? Because it's a chronic ailment.
Yes, ma'am.
So, if you had a direct chance to discuss the history with the patient, anything you would like to get more information about?
She's an educated person. I would like to ask what any other drugs he has been taking.
Yeah, you want to know if there are any filling the gaps in the medication history.
Yes,
okay, very important. Okay, because she is. Why would you like to know about her medication history?
She might have started some medication and skipped medication and improperly diagnosed and taken.
Yeah, because she's teacher by profession.
Which profession?
So it's likely that she must have had taken quite some amount of treatment for a very, very chronic ailment, which you are talking about is for last 15 years.
Yes,
so, other than that, you would like to know something more?
More about her childhood, whether she has 15 years only, how is her school performance and everything, academic activities when she was child. Because 15 years back, she's 32 years only. When she's going 32 years, 15 years, she'll be around the 9th or 10th student. I have to ask her school performance also.
Okay. So you want to have the detail of her history for all these 15 years, because every few years her symptoms have been progressively increasing.
Yes,
And now she is into a status where you have a significant amount of loss of weight, you said? Yeah.
yes, ma'am.
And but still your general physical, your this thing is that in summary, you're not picking it out strongly that she has a loss of appetite, but there's loss of weight.
But
Loss of appetite is also there. Okay, fine.
yes,
So
ma'am. With loss
do
of
you
appetite
think
and
your
kidney.
elaboration on summary is a little less?
Yes, ma'am.
You have given a very brief summary. Then you could have added on a few stressing kind of points. So what is your diagnosis based on history?
She's having long ailment. I like to with loose stools mixed with blood, colonic origin, and large bowel diarrhea. So I'll like to go for differential diagnosis.
So how did you
First, I like to
differentiate that this is large bowel diarrhea?
Small of quantity, not cold swelling, and frequency also there. So I like to large bowel diarrhea.
Okay.
And mucus research indicates that irritation and nocturnal incontinence also there. It's rectal symptoms, irritative rectal symptoms. I like to offer large bowel diarrhea. Small quantities. And,
so what all disease would fit in? So what all disease will fit into your history as of now? Hello? Your voice is gone. Am I audible? Hello?
Dinesh, you are not audible. You are not audible.
Yeah, what all, is he talking? Or?
I think there is some loss of connection, I think.
Yeah, because his voice was breaking every now and then. Can we connect him in a better way? His history and all, I couldn't, his voice was breaking.
Audible, ma'am?
Yeah, now
Dinesh,
you are better. So what
So what are
all do you
different?
put differential diagnosis based on simply on history?
Simply on history, I like to go to inflammatory bowel disease. Most inflammatory bowel disease, one, and history of significant loss of weight and loss of appetite within these last 6 months, 16 kg she has lost the weight. So second different diagnosis on the background of inflammatory bowel disease and malignant transformation. And third, I like to offer different diagnosis, multiple colonic polyposis maybe of the differential diagnosis from the history. I can.
From the history, how can you put it with multiple polyps? Of course,
Yes,
polyps may present with diarrhea.
Yes, ma'am. Polyps may present. The last option I have to.
So in IBD, you said I will put first as IBD. So which IBD?
Ulcerative, like ulcerative colitis.
So in your summary, you did not give any importance to the pain abdomen which patient had from last 1 year, which is periumbilical and which is a very important part. So how will you explain? I think that you should include in your summary. That's a very important point. And second, how will you explain those pain symptoms with ulcerative colitis? Suppose this is your first differential diagnosis.
Outstanding ulcerative colitis involving the right colon, may be associated with pain during the umbilical pain, and when the and colitis extending into the ileal region also, going for indication associated with pain, abdominal pain.
Dr. Ganesh, you need to understand that this patient is having history of 15 years.
Yes, sir.
Patient might be having some kind of a benign disorder for last 15 years, and for last 6 months there is a change in the pattern.
Change in pattern.
In last 6 months there is a loss of appetite, loss of weight, which you have mentioned in your summary also, along with change in the character of the stools also. You need to see what all possibilities has been there. So when you are talking about differential diagnosis, you need to stress upon this factor that this has been in a like long period of time, and now add on this might be the secondary thing which is involved. So just saying that IBD is not enough. So you need to further characterize what is happening with this patient. And you need to, as ma'am said, you need to add some salient negative history in your summary also to say whether things are favor or against. So is there any factor which is against IBD in this patient? Is the history characteristically of IBD? Any factor which is against IBD?
He is again off.
Your voice,
Ma'am?
you're not audible.
No, ma'am.
Yes. Yeah.
I mean, in this patient, negative history or periumbilical pain is also there. All favor towards the IBD and recent change of.
What is the
You said-
characteristic? Ma'am, please.
You said that there were no relieving factors of pain.
They didn't give
Pain in extensive analysis. Where does it fit?
prawns when the recent onset changes.
Because on the background
Compromise
of disease, the disease occurring a little early as compared to the common occurrence of IBD. When does it occur? Commonly, when does it start?
a bimodal distribution will be there. Early first, second, and third decade peak, and another peak is the fourth and fifth decades maybe there. But this patient comes early. 15 years since we have started. At the age of maybe 14 years to 15 years we started.
So this patient had a symptom for last 15 years and there is some aggravation from last 5 years. And there is a pain from last 1 year. As Dr. Vaibhav also asked, how will you explain this change in character of symptoms and
this patient have
appearance of the pain?
Yes. 15 years he might have had a loose tools 5 to 6 episodes. Now with the past 3 years he had mucus discharge to rectum also. 3 years, and the past 6 months she's having a loss of weight.
How you have to explain what is happening in the patient.
Why this is happening?
Why have
there may be either on the background of IBD there may be first one is increase in severity and explain that mucus discharge and
okay, that's one thing. What else?
Second is on the background of long-standing IBD malignancy.
So that can explain your other symptom also.
Yes.
Okay, anybody else would come in and ask something more? So you are strictly on IBD only one. You should enumerate some more differential diagnosis.
And you don't want to consider Crohn's in the differential diagnosis or only ulcerative colitis?
Most likely ulcerative colitis, because Crohn's also a possibility, sir, without
so why you are ruling out Crohn's? Okay, why ulcerative colitis on number 1 and Crohn's on lower down in your differential diagnosis?
First, that ulcerative colitis early age and the large bowel.
So age is in favor of Crohn's or ulcerative colitis in this patient?
Age Crohn's, more or Crohn's. But this patient for the past 15 years is having only 4 to 5 episodes and like large bowels. So mostly colon will be involved with. But whereas in Crohn's it will be involved anywhere from the age. So that symptoms here won't fit. But I'll keep us a differential diagnosis in the last.
Okay. Any other differential diagnosis apart from IBD?
We did malignancy and diagnosis.
Malignancy.
Yes, sir. On the back
Last
of
15 years.
Yes. Recent change in all the habits. That's why one significant loss of weight. I would like to put a differential diagnosis malignancy also.
In malignancy de novo or on the background of ulcerative colitis?
On the background of ulcerative colitis.
Then you should say completely, na? You should clearly.
On the background of. Okay, sir. Sorry.
So you have to like complete your differential diagnosis also at the history that
One is, yes.
This is my case who is having a long-standing diarrhea plus 15 years with a recent change in the habits. So my differential diagnosis would be inflammatory bowel disease, primarily ulcerative colitis, secondary Crohn's disease, and along with she might have developed a secondary malignancy.
Secondary malignancy on the background of
In which region, which is the common site of development of malignancy in IBD, or if you say ulcerative colitis, which is the most common location.
diffusely can occur anywhere in the Poland, long-standing.
Any predilection, any. And suppose if the patient is having only proctitis, left-sided colitis, or pancolitis, which disease tend to have more tendency to develop malignancy? In ulcerative colitis, if the patient is having different spectrum of disease in ulcerative colitis,
Yes,
which spectrum of patient have more chances of developing of malignancy?
The patient have pancolitis. Pancolitis have more than 8 years of onset. They'll have more increased chance of malignancy. Whereas left side colitis, more than 10 to 12 years, they can have increased chance of malignancy. And the previous history of in their family, if any colorectal cancer, if they have increased risk of malignancy on the background of IBD. And
what is the incidence? You know, what is the incidence of malignancy in ulcerative colitis?
2 to 5%.
Is it depend upon the duration of disease or it is?
Duration of disease?
Based on the duration, sir. Any patient pancolitis more than 8 years have a risk, increased risk. And then the cumulative risk increases 2% for the first 10 years and 8% for 20 years and 18% for 30 years. They have ulcerative colitis.
Any other differential diagnosis in this case? Any other DD? Apart from IBD, any other differential diagnosis?
Polyposis is probably one of the possibilities.
All these loss of weight and appetite can occur on the background of any other causes of diarrhea. If you go back to causes of diarrhea,
a chronic diarrhea infection is polyp, but this much long duration of the 15 years won't fit. Short duration of diarrhea we can accommodate, but in this patient, 15 years is having on the background, so most likely IBD comes in the diagnosis.
You have heard about something called as non-specific ileitis, which is not IBD.
Sorry.
Chronic non-specific ileitis. They also have similar overlapping symptoms, wherein you will come to the diagnosis on exclusion. Okay, so IBD, you keep Crohn's down in your list, but you're more onto the side of that it is UC. And your first differential diagnosis is IBD. And then you also put a diagnosis of malignancy on the background of IBD. And you're thinking more in terms of a diffuse long-standing disease, is it so?
Yes, ma'am.
Okay. With you don't have a proper history of medication and any, because what would come important of 15 years or history of pain, abdomen, diarrhea would be the drug history, the history of relapse. Okay. And did she have, you have to ask about whether she had any intervals of being asymptomatic for some time. Progressively increasing or persistently present for 15 years need lot of, specification in history, which is missing. Once I gave you a chance that would you like to know something more in history? Because it's very typical of all these inflammatory diseases that they go into exacerbations and they go into remission as well, if she doesn't have any proper medical history also. So that and all is missing. So your history has some lot of,
This is one of the negative points, that known medical history in case of IBD for last 15 years. It is very unlikely that patient is having IBD for last 15 years and she has taken no medications specific to this disorder. So this is one negative point. So you should keep.
Okay, I think we have discussed history for some
Next,
time.
what do you want?
Dr. Harjeet, you want to make any point, Doctor?
No,
Add
I
on.
think that's all because everybody has wanted like this history was provided to you. Suppose if you have taken this history yourself, then I think then this there's a very important point. Patient is a educated, she's a teacher, history of 15 years, so much of diarrhea, and she has not consulted, she has not been investigated. I think these are the old points when we are considering the IBD. So I think that point should be considered when you're taking the history. I think we can move to examination.
Please proceed, Dr. Ganesh.
Examination.
Yes. General physical examination. Patient is conscious, cooperative, and oriented, and height is 1.5 meter, and weight is 55 kg, and BMI is 24.7. Is well built and well nourished, and ECOG is 1. Breath holding time is 32 seconds.
What is
General
odd in
no pallor,
examination,
no.
Dr. Ganesh? So you just explain general physical examination. What is odd here? Is it expected findings in this patient?
No, sir. She is well preserved and well nourished, and weight is also BMI also the fair aspect 24.7 for women already lost 16 kg.
Yeah, I think these are the very important points. Patient is having diarrhea from last 15 years, and from last 6 months she has lost 16 years. Still her ECOG is 1, and he's a good BMI.
Yes.
So I think these are the odd points which you should also point out when you are doing the examination. Usually you will not find like this when this type of history will be there. Okay, please continue.
Examination. No, there is no pallor or no icterus or cyanosis, or clubbing or lymphodenopathy or fetal edema. Pulse rate is 88 per minute, and BP is 128 per 86 mmHg, and respiratory rate is 14 per minute, and CFF right. Abdominal
Okay.
examination, inspection. Abdomen is kept with umbilicus and central end position and inverted. All quadrants of abdomen move equally with the respiration. No scars are visible peristalsis or skin nodules or enlarged veins. No fullness or visible lump. Corneal orifices, no visible coughing pulse, and no renal angle fullness. And palpation, abdomen is soft and non-tender, no organomegaly or any other palpable lump. Hernial sites, no palpable coughing pulse. Percussion, liver dullness, upper border in the 15 intercostal space, and liver span along right mid-clavicular line in 13 centimeters, and plaques are tympanic. Auscultation, normal bowel sounds heard and no brute or venous sound. And digital rectal examination, perianal skin normal, normal sphincter tone, no polyps filled. And glove stained with normal fecal stain. Proctoscopy, no visible polyps in the visualized rectum.
Dr. Ganesh, we
What
cannot
else?
see your screen.
You can share your
That-
screen. Share your screen.
Share your screen of examination, sir said, because there might be students who are not able to hear your voice. Your voice is breaking. Share your screen about examination.
One thing.
Okay, so you have not picked up anything positive in both systemic and general physical examination. Is that so?
Yes, ma'am. Yes.
With
yes,
with long-standing bleeding per rectum, now she says that she has these symptoms for at least 5 years, and she doesn't
Yes,
have any pallor. Then she has. Yeah, he's sharing his slides. Okay,
This
fine.
examination finding was provided to you. So what do you think? What is missing here, or you want
Yes,
to
ma'am.
know? What else you want to know in the examination, or this examination is sufficient, which was provided to you?
The examination, to examination, oral cavity, I have to examine patient. Any other after ulcer or
Anything else? Okay.
and examination of the articular surface and joint muscle skeleton from any extraintestinal manifestation of IBD to rule out that joint.
So there is no joint pain
as
in
well
the
as
history.
examination.
So is it possible that patient did not have any symptoms of joint pain, and you will find something in the examination?
It's possible. Patient might
Possible.
have without not painless.
Okay. Anything else? In proctoscopy, you
on-
saw just a polyp. You don't want to show anything else. You don't want to see anything else. Your first differential diagnosis is IBD.
the mucus discharge is there or not, whether it's
Mucus
gauge,
discharge, you
gauge.
can. In proctoscopy, what else you want to see other than polyp when your first differential diagnosis is ulcerative colitis?
Ulcer, any ulcer is there, rectum is involved or not, any friability is
So
there,
you
erythema is
did not
there.
see that. You did not see any
Yes.
rectal inflammation. Patient is having the rectal symptom. Patient is having the incontinence. Patient is having the urgency.
Urgency, everything, but it is not there.
No, that's okay. That's not been provided to you. So you should ask. You want to see the rectal mucosa whether it's normal or it's inflamed. Okay.
So why is it focused only on polyps in the rectal examination? Because what are the findings of your IBD when you look at rectum? And which is the commonest site involved, Dr. Silva?
Ma'am, starts from rectum, almost always ulcerative colitis involve the rectum. And
So 90% and above are likely to involve rectum.
like to involve the rectum starts.
So a surgeon generally with good skills of examining rectum through a rigid proctoscope can pick up any findings, isn't it? Then you
Yes,
tend to refer for a colonoscopy if you don't do it yourself. So enumerate the findings that you'll see in rectum. And how would it be different from an anticipated? See, because based on history, you said that this is large bowel diarrhea, but diarrheas have so much of overlap, and it can be with some blackish stools and some altered blood sometimes can involve terminal ileum also. So what all would be, what all findings you expect in an IBD, UC and Crohn's? Because you can make a good
IBD
diagnosis based on your rectal examination alone.
Yes, ma'am. On inspection itself, perianal inspection, whether any multiple sinus or non-healing ulcers, if it is there, it will use the diagnosis towards the Crohn's, which is perianal involvement will be more than the Crohn's. Whereas in the ulcerative colitis, in the rectal mucosa friability and on a good elimination, whether loss of vascular pattern or any bleeding erosions is there, or any sort of polyps can be there, or bleeding leads to touch, like that we can see in the clinical examination of the proctoscope. Rectum, ulcerative colitis, we can see.
What are the pseudopolyps in ulcerative colitis basically?
These are the hypertrophy of the mucosa. Because ulcerative colitis is limited to mucosa, so there will be hypertrophy.
Why they would be hypertrophic? So basically, actually, that area of mucosa represents an area which has not lost its character.
Yes, ma'am.
And because of the hypertrophy of the submucosal areas, it will protrude out. And
yes,
that's why it is a pseudopolyp.
yes, pseudopolyp, not a.
Or it's an inflammatory polyp. Okay. So anything else, Dr. Harjeet, you can come in. So do you find?
So I think you're now after examination, what is your differential diagnosis? Same or did it change? Now we assume that on proctoscopy, rectal mucosa is normal because that's not given here.
Yes.
So would you like to consider any other differential diagnosis after examination?
I'll stick on to my different.
So what else
I
you
would
want
like to do for other investigations.
So what do you want to do?
I like to do basic investigation along with full-length colonoscopy for this patient. After that, take a biopsy in affected areas and then do medical treatment.
What precaution you will take in this patient before planning the full-length colonoscopy?
This patient already having routine schools. We have to first electrolyte correction, admit and give.
No, that's okay. You said the pulse rate is fine, everything is fine. and there is
Okay.
no signs of any dehydration or electrolyte imbalance. So why you want to correct it? It doesn't look like there is anything like this. So for colonoscopy, what in this patient, what precaution you will take? Or
Patient gentle colonoscopy, minimal insufflation, multiple biopsies to be taken. And
so you also
no
said that
bleeding.
patient had some change in character of the in diarrheas, or and you also kept the possibility of
Mucus
malignancy
Yes,
also. So why there is change in this character, and if there is a malignancy on the left side, think of what can happen.
but maybe stricturous lesions might be there.
So I think that's very important when you're planning colonoscopy, that you should be
Colonoscopy.
careful. Yeah, when you should be very careful
Very
when you're planning to give any colonic preparation in this patient.
Yes.
Okay, what do you want to see in colonoscopy?
Lens colonoscopy. First, we'll have to see the
And you would
extent of the
for such lady, you'll directly jump with colonoscopy only as an investigation, or you would do some other investigations as well?
first basic first complete
You'll have to
hemogram
correlate
along
your
with ESR.
colonoscopy and other investigations. Okay, fine, continue.
Yes, sir. Complete hemogram along with ESR, with the renal function test, with the CRP, C-reactive protein, as C-reactive, and basically it was like stool culture and sensitivity, stool ovasis, and along with colonoscopy.
Why
You did not
stool
keep
culture?
culture and sensitivity. Why? You did not keep any infective diarrheas in your differential diagnosis.
Super added that may be there. So we have to first always see, and clostridial difficile. If you might have taken multiple antibiotics and not telling the history, there may be possibility.
Okay.
Clostridial difficile.
Anything else in stool you would like to do specific for your diagnosis?
That's fecal calprotectin. Fecal calprotectin.
So you should not be hesitant about thinking that they are. I am telling about specific investigation because you are very specific in your diagnosis, isn't it? You did not keep any juvenile polyposis. You did not think about any hyperpigmentation you would like to see, and then you thought that it's an inflammatory bowel disease with malignancy. So as Harjeet rightly said, that you have to think about any stricturing lesion encountered during colonoscopy, and you will have to take care of all those things. And then importantly is that you should not be reluctant about saying that now I'll do a calprotectin as well, because I think it's now freely available and everybody wants to do that. Other than the important inflammatory markers, you said that you like to have an idea about what the CRP of the patient is, and then you see the counts, the CBC, her anemia status.
Though she is not having bile, but looking for the hemoglobin before doing colonoscopy is important. One thing. And second thing, there was no history, any medical management history in the past, which usually patient will have if the patient is suffering from ulcerative colitis with normal rectal mucosa on proctoscopy. You should think of the disorder which ma'am says, juvenile polyposis coli, and you should strongly say that the highly possibility of colonic polyposis in this case also, and considering a young age also. So you should come out with this differential diagnosis after your examination, that this would be, I would like to keep these differential also in my mind before I further go for investigation. Okay. So
then with polyps, if you think of looking at polyps, you have many differential diagnoses, isn't it, Dr. Silva? Yeah. So let everybody know the investigations.
Hemoglobin is 12 grams, fairly. The total count is 9,300 only. Platelets 3.2 lakhs. Normal.
Okay.
And blood urea and creatinine. Urea is 17, creatinine 0.5, and electrolytes also within normal limits. 133, 5.1, 97. LFT, total bilirubin direct SGOT-PT.
Just see the report and make the difference. Just
You-
Yes, sir. It's
you
normal
said
limit.
they are
Within normal
normal.
limit only.
Yeah.
Yes, sir.
okay.
Normal only.
Okay. Any raise CRP is there?
No,
Normal.
no
CRP not provided.
CRP.
Okay, it's normal.
The calprotectin was not done.
Okay.
So what is the value of how will you value of fecal calprotectin occur, Ganesh?
And 50 to 100.
No. I'm asking doing a what is the value of doing the fecal calprotectin when this type of history is there? Is it important or is
Yes, it's important only. It's important because it is a direct mark of mucosal inflammation. It has more neutrophils will come and degraded, and the fecal calprotectin levels will be increased. So it's
so
fairly
now
correlates with
people are using it as a
inflammation.
very important screening test for the inflammatory
Screening
disorder
test.
of the colon or the small bowel. So I think it's very important to do a fecal calprotectin even before, when there's a diagnosis in doubt, even before doing the colonoscopy.
Especially in the background of such a long history, if you're not able to differentiate between your patient has blood in diarrhea and mucus, so your history was more clear and you are inclined towards IBD. Correctly so.
Yes.
So now all your, you would like to know your colonoscopy findings? You're done with your examination, your
Yes.
lab investigations?
C-reactive protein, CRP now.
Okay.
Not done.
C-reactive protein.
Not done.
Okay. Then I'll go to colonoscopy.
Okay, colonoscopy, you read the findings in detail.
Multiple sessile polyps present on the rectum, sigmoid colon, descending colon, and transverse colon, and ascending colon, and cecum. Ileum was normal.
So what's your diagnosis now?
Multiple polyposis.
Multiple polyposis.
What multiple which
polyposis.
kind of multiple polyposis you want to say?
The sessile polyps take biopsy and see.
You want to do the biopsy, no?
Biopsy.
Yeah.
Biopsy is what means.
So you don't have any mass lesion over there, which we're suspecting
Yes.
on the background of IBD. You don't have these features are not very typical of IBD as well. These polyps, isn't it? So you're changing your diagnosis right now?
But maybe I'll like to go for
This colonoscopy is of
yes,
good
ma'am.
value, or you think that this is
Yes, ma'am, it's a good value. Multiple
incomplete
polyposis.
kind? What do you mean by polyps plus?
Polyps are present, but they didn't mention about number of polyps.
So what is the significance of number of polyps?
Whether less than 100 or more than 100 in polyps.
Hmm.
And then, if you want to say it's familiar, polyps, minimum 100 polyps, more than 100 polyps is there. Even less than polyp, attenuated FAP may be there.
So it is not more than or less than. It is when the polyps are more than 100, it favors some other diagnosis, but it is not a
not less than and more than 100.
It's not a cutoff, something like that.
100 to 1000 maybe.
So can we assume that everywhere they have put a plus, so there are lots of polyps?
Multiple. Yes, ma'am. Yes,
multiple.
Multiple polyps.
Okay. Or you'll call your medical colleague and ask him that what impression does he have? Did he make an impression over there? They usually make an impression or a diagnosis, na? On colonoscopy.
Yes.
And what other thing endoscopists do? Because in your differential diagnosis, you have a doubt of malignancy. So something use a different maneuver in their endoscopy to see whether there are any suspicious lesion for malignancy or not. What is that?
Impression was given as a very familial adenomatous polyp.
Okay. No, it's okay. That is okay. But
Okay.
they do some maneuver or they do some imaging in during the endoscopy, what is that?
Chromoscope.
Endoscopy, the narrowband imaging, which
Narrowband imaging,
give you us with any suspicious lesion for malignancy on. So he told that diagnosis, the impression. What was that?
FAP.
Familial
Yes,
adenomatous.
FAP.
Familial adenomatous polyposis.
Ganesh, this is very clear picture of colonoscopy which was given to you, that there is a multiple polyp in. They have separately mentioned each and every area. Suppose I tell the colonoscopy shows the multiple polyp in the colon. So is that sufficient, or you need this type of clear picture, and why?
Extent of the disease, we have to see.
That's okay. I
how
told
many-
there is the whole of the colon is having multiple polyp.
Is that okay with you, or you want?
Is that okay? Yeah. Or you separately want to know that polyp in the cecum, ascending colon, transverse colon, descending colon, rectum, sigmoid, and why? You
What
got
about
my
size
question,
of the
huh?
polyp? If one of the polyp has overgrown in size?
risk will be more, ma'am. Malignancy risk will be more. There is
And
more.
they have not mentioned the size of the polyp.
Yes.
The size of polyp matter.
Yes.
What about invasions? Matlab, they are all flat polyps, na? Sessile polyps
Yes,
are.
that will be.
Mhm.
Is the size of the polyp matters? Suppose.
Yes, sir.
Oh, why? How?
More than 2 centimeters chances of the malignancy will be.
More than 2 centimeters, yes. More than 2 centimeters have high chances of malignancy, yes.
So, Ganesh, we are talking about now the diagnosis is clear FAP or with multiple
Yes, sir.
polyposis, and the age of the patient is around 32 years. So now does it matter?
Yes.
In your proctoscopy, you did not see any polyp in the rectum.
Definitely
No,
matter.
in even
Yes, sir.
examination, you
They
did
have
not see.
chan-
But colonoscopy said the polyposis in the colon. So you really want
Yes,
to
sir.
map this polyp in the rectum? Is it important? That's why I was asking this question. Is it important to know the extent of involvement of the rectum by the polyposis syndrome or not?
Yes, sir. How many polyps in the rectum?
So that's important.
If they want to keep the rectum, want to keep the rectum, whether surgical management, the follow-up,
It changes.
So that's why I'm saying
increasing chance of malignancy.
that's why I'm saying when you do a colonoscopy once, you do it completely and take this information once for all, so that you should be clear. I don't know whether you will ultimately what surgery you will do, but at least this information should be with you before planning any further treatment in this patient. What else you want to do? You have a colonoscopy, the biopsy showed the adenoma with the.
Show the biopsy report, please.
It was adenoma with low-grade dysplasia.
Adenoma with low grade.
So it is an adenoma. So it is an adenomatous polyposis, basically.
Adenomatous polyposis. First, I like to discuss it. Is having increased risk of colorectal malignancy. So we have to do total colorectomy. If the adenoma is less than rectum 20, you can keep the rectum
No.
and do a release.
You will directly plan surgery with this, or you don't want to do anything else in this patient?
That's
Sorry, pardon?
other system like ophthalmic examination for CHRP, we have to see.
So what do you want to see in that? Why you want to do that?
Congenital hyper.
When you know that this is the familial adenomatous polyposis. Now after this, you need to see this is the spectrum of disorders.
After that,
what all the things you need to.
Are you missing with some more investigations as well?
Yes.
You're talking all through, you are saying that I am thinking of a malignancy.
So she had a recent loss of weight and loss of weight. So do you want to see anything else or any other association with this disorder? Any other problem?
The familial adenomatous associated VGScopy always could be done.
With the
See, you have
upper
some
gastrointestinal
associated issues with
associated
you are
chest.
jumping. Now you are jumping straight away to surgery. Planning is okay. Colonoscopy is very important. That you should have all details. But won't you do any imaging, cross-sectional imaging for this patient?
Cross-sectional imaging is you have to do. Contrast enhanced CT abdomen.
okay, any other
Before
thing?
that,
First plan
because
your
upper GI is
upper GI endoscopy. Okay,
Okay.
upper GI endoscopy also
what
should be there.
Why you want to do
what
upper
is your
GI
intent?
endoscopy?
The intent is to see whether any polyps there in the stomach, and second possible malignancy, ampullary malignancy, duodenum we have to see.
So
Increased
which
chance of
polyps are
malignancy.
more relevant to you, stomach or duodenal?
Duodenal polyps. Stomach
Why?
mostly fundy-gland polyps. The
And
chance
can we
of
have?
malignancy will be more, again, common.
Okay.
So not knowing on the background of not knowing the number of polyps in each area, rectum, ascending or descending colon, what else would you like to, think about? And you wanted to do an upper GI, which, disease have more common involvement of upper GI as well, FAP? Or some other, there are many spectrum of
Familiar.
disease in polyposis, which is wrongly known as non-polyposis also, isn't it? That is why you would
Yes,
like to do an upper GI endoscopy. Say a Lynch syndrome, you'll have to look
endoscope.
all co-associations. In syndromic polyps also you can have malignancy, but roughly we all are thinking that there are multiple polyps and we are putting it up as FAP, assuming that's 100 and more. Okay, so you did an upper GI endoscopy. Can somebody share the report? Yes, doctor. Read it
Multiple
for
polyps.
everybody.
Diminutive sessile polyps.
Okay.
Diminutive sessile polyps only in the body and fundus, and three superficial base ulcers in the antrum. The largest is 6 into 6 millimeter.
Okay, so you again have multiple polyps,
And
sessile polyps in the stomach.
stomach, yes.
Okay, multiple means they said only 3 are there?
Multiple sessile polyps in the body and fundus, only 3 ulcers in the antrum.
Okay, 3 ulcers, superficial ulcers at the end. Okay.
Dinesh, now how will you explain the weight loss and uh, the rapid deterioration in last 6 months? Your colon is showing just polyps and their adenomatous, and even upper GI is normal.
And biopsy also is adenoma with low grade
Yeah,
dysplasia.
No grade dysplasia.
yeah. How will you explain? Is there a way to explain these symptoms? Can this colon can have some hidden malignancy which is not picked up by our colonoscopy? Is it possible?
Not picked up by all.
So
Yes,
I think you
possibly
should keep
hidden areas of
that
coloscopy.
yeah. Then you should keep that thing in mind. That's why we take a multiple biopsy from multiple areas. Sometimes it may not be possible that you might have missed that part. And okay,
Anything
what
you want
else?
to add to your planning? Any other investigation?
Cross-sectional imaging.
Anything other? Any blood investigation which we are missing?
It's very simple. You are telling that there can be a malignancy over there. Before colonoscopy also you should have thought of doing a tumor marker,
CE, sir.
isn't it?
Tumor marker CE is partner CE level you have to see.
And you said also, as ma'am asked about any cross-sectional imaging. So would you like to do that?
If there
Would
is
you like
hidden
to do it? And
malignancy,
what would you pick up, a CT or an MRI?
in this patient, the CCT of the abdomen and the pelvis, we have to do, along with rectum MRI, we have to do. Rectal malignancy.
So what do you want to see in CT?
So first extent of the disease and stage of the disease.
CT
Any
is
other metastasis?
So this is malignancy is still not proved. So then it is not good to say metastasis. You have to see first the
Malignancy.
scan. Where is the primary?
1 minute.
So CT is not only for the purpose of looking into metastasis, na?
It's
That
past
is
the
also
stage
co-finding
where
the
it is
disease.
started, primary lesion,
Yes,
the extent of the
primary.
disease.
Okay, read the CT they are showing you.
1 minute.
Are you scrolling this?
Yeah,
Yes, sir.
somebody showing the rectal area now. Going back.
Any positive finding?
The contrast NNCT,
Yeah.
there is no ascites, there is no free bleed. Liver seems there is no. It's
Any positive finding, Dr. Ganesh?
sir, I couldn't make it. Only dilated bowel was only.
Not dilated.
Not dilated, they're normal bowel loops.
Small bowel.
Dilated.
So what do you
I
want to
think the
see?
funding area showed a small polyp, not very sure. Okay, but grossly there are no positive findings. Is it so, or you are
No
having
positive finding. Yes.
No, this
anybody who
colony.
wants to put in something, some positive if they have picked up can.
Any other thing you want to see in CT scan in a case of FAP?
She's a female patient now. What all association you?
Endometrial carcinomas,
FAP के साथ.
thyroid.
That is not, that is with the HNPCC.
Is it?
But
Not with this. Any other thing?
What is the most common association of FAP with the extra desmoid tumor you should see, na? What
desmoid.
what percentage of patient with FAP have desmoid malignancy or desmoid tumors? Is it
More than 50 to 80%.
no? It's too
No,
much.
not so high. It's not that much.
It's 10 to 20%.
You have to see the retroperitoneum, see if it is involving the any lesion in the root of the mesentery, which is the most common site. So can you proceed further?
And Ganesh, you said that you will do MRI pelvis. At present, we don't have anything in our maybe with the colonoscopy and other investigation. We
CT.
did not find any lesion in the rectum. So I don't think so it's a correct to do a MRI pelvis at this stage. Na? First of all, that you can do CT, you can screen everything, and then you can plan.
And then we can plan.
Yeah. Now what you will do?
Here we can.
Can we have a CT report? Suppose this patient comes to you at the age of 17 years or 18 years, and these are the findings. Is your management will be different or same? So this is the CT finding. There is no abnormality.
Abnormality.
Yes, now.
So now you answer what you will do now. Then we'll ask the second question.
Then we have to counsel the patient that possibility of malignancy will be more in the FAP before the age of 30, 39 years, there will be definitely colorectal malignancy. So before that age, you have to do total
no, what you will do to what you will do now to this patient? You have investigation, you have colonoscopy, upper GI, CT, everything is with you. What is your plan?
Counseling the patient.
No, first tell the plan, then we'll counsel. Na? First tell what you will do, then we'll explain that we're going to do this surgery or whatever. So you tell us what surgical plan or medical plan you want to do with this patient.
We have to start around cylinder.
Sir, pardon?
Now you have histopathology diagnosis also, you have a CT on background, and you are now making a diagnosis of FAP.
Family diagnosis qualification. Screening, I have to screen screen all the family members.
Screening will be a second thing. Na? You do, patient came to you, you treat this patient first. So what you will do with this patient? What treatment you will do with this patient?
Surgical management, total ileal pouch channel first. Total proctoclotomy with ileal pouch channel to plan. But she completed only one child, so if he wants to have another child, he'll wait and postpone. Then
for how long you want to postpone? For how long you want to postpone?
And how sure you are that there are no, in situ malignancy when you remove at the age of 30 plus colon and rectum, you pick a few malignancy over there, and that is also based on how extensively your pathologist has evaluated the specimen.
You need to see that what is the average age or what is the median age of development of FAP, and then what is the median age of development of colorectal carcinoma in patients. So what is the average age of FAP and what is the average of CRC?
CRC 39 years before the before the age of 40 we have to 40 years.
She's
32, sir.
32, okay.
So by the age of 39 or 40, more than 90% of the patient they develop malignancy. So malignancy can occur before that also.
This is an average, basically. It can develop before or after also.
It can occur before also, but by the 40, the majority of the patient develop malignancy. Okay, almost 100% penetration is there.
So that's the way you need to counsel the patient. That your disease already, like for last 15 years, you are having symptoms, and as the age proceeds, the risk of malignancy further increase.
So patient says that I have completed my family. What surgery you will do?
I'll go for total protocol with the ileal pouch channel.
How this total proctocolectomy will be different from the ulcerative colitis total proctocolectomy, or is same?
So here we have to clear the oncology, more sticking up, removing of more lymph nodes. More lymph nodes.
So what you will do?
More.
Just okay. More lymph node is fine. How will you do the more lymph node?
Till the root of mesentery, you have to go on to the catheter. And then ileal channel response. And the rectal transition zones also we have to be on continuous surveillance when you go for maybe.
Suppose this patient comes to you at the age of 17 with the same, almost similar finding, then what is your plan will be different or same?
17 years.
Yeah, patient had this symptom at the age of 17 years. Na? She was 17 years when she developed diarrhea episode. Suppose at that time we have investigated the patients, or maybe at the age of 18 years, you have a similar finding. So is the management will be same or it will be a different?
I'll ask her about the whether she counsel about the possibility of malignancy and on her keep on organ surveillance and whether she wants to come to go for marriage and get children like that to ask. And then regularly, yearly, I have to go for colonoscopy and multiple random biopsy. And before she turns 40, I have to go for surgery. If it is already a biopsy proven malignancy is there, I'll go for colostomy in that age.
So you want to say that in FAP, we will wait till age of 40 for doing the colonic surgery?
Before you have to do, sir.
Yeah, we will, if we have some more guest seniors among the, those who have joined us can come in and give a valuable point or put up a question in between. Because see, what all about good about FAP is that you have picked up a disease and you want to prevent malignancy.
Yes.
Okay. So you'll have to see the age group, plus you have to see the interest of not developing the malignancy. So in this subset of patient who is 32 years of old age and she has symptoms which are inclined towards malignancy, your resection would be, see, the resection involves all colon, total colon and rectum based on what quality of life you want to give her. If you leave a small rim of rectum, it's an acceptable treatment if you can put the patient's rectal rim under surveillance, but you don't leave a whole rectum over there. That makes the post of symptoms a little less. So what they were trying to ask you is what kind of colectomies do you know? If you assume that there's still some malignancy which is missed, or preoperatively you did your CA 19-9, which was on higher side. She has loss of weight, she has loss of appetite, and she was a heavy lady or an obese lady who doesn't show much change in the general physical examination. Along with the colonic margin, you'll do a D1, D2, D3. So D3 kind might not be required. That is what Harjeet wanted to ask you. What would be your planes of dissection and what kind of colectomy you are going to offer the patient? When in contrast to somebody else whom you took a call of doing a colectomy early. So anybody in the audiences would like to ask him something? What is the treatment of desmoid if it was associated desmoid over there?
Desmoid is there. First, see the where what is the size and what is the extent it is there involving. Then it depends on the classification. We have to initially start whether the associated bowel obstruction is there or not, and how much mesentery it is. Stage the disease CCT, and we have to give namoxifene or relaxifene, like estrogen receptor blocker, and extensive surgery could be avoided because it leads to a lot of loss of bowel length.
Would you do any genetic testing for this patient?
Sir?
Any genetic analysis for this patient?
Genetic analysis of this patient.
which patient you are more likely to have some kind of genetic positivity? Suppose this lady had a colonoscopy, showed a malignant lesion over there as well in sigmoid colon or rectosigmoid junction. Would the treatment change? So Dr. Varshney asked you that what kind of genetic testings you would do for the patient. Which kind of polyposis coli you are more inclined to do genetic testings? Or you should do it to all? What genes are specifically?
APC gene.
APC gene are involved in?
I think Dr. Vaibhav is asking, even in FAP, if APC is mutated, then different type of mutation can have a different type of
Phenotypic.
spectrum of presentations or risk of malignancy. And that's why I think this is important to do a genetic analysis in FAP patients also. And even you can predict the familial involvement also. Okay.
Yeah, that is more important. What Harjeet said, that you can predict familial involvement as well, the family members.
You need to screen the family members also, so that you can take preemptive action or surveillance in those patients also, so that they don't develop any malignancy in future.
I think we can invite questions from other senior people in the group. Dr. Kapoor is here, Dr. Shastri is here.
So, Harjeet, you can just summarize what is performance status of the moderators. And then there are a few questions for the students have posted. The moderators can address them on Q&A. Then we can open up the other faculty to join.
Madam Sadaf can.
Yeah, where are the
comment.
questions? Yeah.
Q&A.
Moderators. Where do I take the questions from? Do you have? I have only 2 messages from
Not
Pradeep
messages,
sir.
Q&A.
I-
Q&A. Q&A.
Q&A. Okay.
I think Salva, your performance was I will rate it as an average because you need a hint at many places now where you could have done better. So for many answers, we have to probe you a little more. So I think we can.
At the end of
Yes.
history, you should have more differential diagnosis. You should also say that it could be infective, but the chances are less because of long history. Okay, so you need to give more differential at the end of history, and then you need to, like, after the examination, you need to categorize
Okay.
them.
Q&A is there. Okay.
Okay, so as ma'am, please.
Yeah, there's Dr. Narendra who has asked quite a few questions. A colonic polyps doesn't explain the peri-umbilical pain in this patient. Do we need to add a CT enterochlesis? So he probably has put it early while discussing. So CT scan was done, and CT enterochlesis may show you the stricturous area. And definitely, if the disease would have inclined towards UC, inflammatory bowel disease, then enterochlesis was a good investigation. Not only a malignancy, partially or intermittent obstruction in small bowel can cause, definitely. Can it cause weight loss? Definitely, it can cause weight loss, because anybody who wants to come in, Harjeet and Dr. Varshney, you can add to the point which I make. Because this kind of chronic diarrhea, there are many patients who have other reasons of diarrhea. Say there are endocrine reasons of diarrhea, and they have secretory diarrheas. Or if he said that there was a stricture, there was obstructive kind of diarrhea. So all these, if they are chronic symptoms, they tend to lose weight. Especially the patients who have IBD. So that can be a cause of this thing. Small bowel he has ruled out specifically, but we did not rule out initially in clinical history. There was always a possibility that there might be Crohn's as well, but then colonoscopy did not suggest that. And Dr. Rishi is asking that is there a hypodense lesion near it to be? Can he explain?
I think he's asking
Near
for
it to
it was a focal fat
Focal
sparing
fat,
with
segment 4.
a segment
Okay,
4B.
liver, you meant
Yeah.
liver? Okay,
Left
you have,
lobe. That
he,
was focal
it
fat
looked like
sparing.
that. Even I noticed that, but that was a fat sparing area. It did not have a typical character of any Mets or any other lesion. So Dr. Jaya Anand is, should we do a genetic testing to confirm FAP? So that's an important thing that you can add genetic testing for FAP, especially there's a proper chart of what genetic testings you should be doing. You should be doing. APC gene is always involved in adenoma carcinoma sequencing, but if it is not FAP and if it is Lynch syndromic kind of a disease, then you have to be aware about your microsatellite instability as well. Because that area, the line of treatment changes. And then Dr. Rahul Gautam is again asking about genetic workup, which might be very important for these patients. And you will have to screen the family as well. Based on that, you have to take a call that how early you should start screening the family. Discussion should have been preservation of rectum or not. Yeah, that is what we took it at the end, that in younger patient, this is the last question, I suppose. In younger patient, for better quality of life with no definite malignancy or no inclination, as you said that in this particular patient, there were no features suggestive of malignancy. There was, if you would keep a rim of rectum under surveillance, it's not bad, but that depends on what kind of disease you are handling. If it is, in general, if it is polyposis, which is FAP, people do advocate removing the whole of rectum and not keeping, because the incidence of malignancy is very high. And if it's a sparing kind of polyps, like in Lynch syndrome, you can leave a significant length of rectum if you don't have too many polyps over there. So all based on distribution of your disease. And in fact, generally, majority of us agree about not leaving at least a significant length of rectum.
So abdominal colectomy with ileorectal anastomosis, as ma'am said, only to be done when there are only few polyps, which can be removed endoscopically, means the rectum is clean when you are doing this procedure. Second thing, the patient is willing for active surveillance every 6 months, 12 monthly, because if there is any development of malignancy, you need to take a call. Then also, then further, as the literature said, you can do genetic testing if what kind of mutation it is, where the mutation lies, and on those basis you can take a decision again. And the last thing is, what is the duration of the disease? I think in this patient, the duration of 15 years. As the duration increases, risk of malignancy increases. So in those cases, if the duration is long, better to err towards doing the rectal resection. Yes, your point is valid that she has to have 4 to 5 episodes of stool per day. But if you compare the risk versus benefit, the benefit is toward removing the rectum, which is better, because doing a second surgery would be again difficult, and creating a pouch after doing ileorectal again becomes difficult.
And one more point, I think complete surgery is total proctoclectomy with ileal patch anastomosis. And if you compare the pouch of FAP with the pouch of ulcerative colitis, these pouches are better tolerated and a better quality of life when we compared it with the ulcerative colitis. So I think the complete surgery is total removal with ileo-anal pouch anastomosis.
Risk of pouchitis is less when we do for FAP.
Yeah, if there are no comments, we'll move to the other faculty. Ganesh, I think your performance is, as Harjeet has said, is an average, because every time I could see the moderators are coaxing you to get the answer out of you. That should not be the case in the exams. And the other thing I was not happy with is when you summarize, your summary was very it's incomplete.
Very brief, short.
So a summary should reflect the important positive and important negative points is very important. And by looking at the summary, the examiner can tell you whether you know the subject or not, because you should know what is important, what is negative points. And then you have to differential diagnosis, you're not even considered, because I didn't see in your slide your differential diagnosis. In the exam, you should write down your differential diagnosis. Your summary should be crisp, important positive and negative points should be included for the examiner, because sometimes in the lack of time, sometimes the examiner directly asks you to summarize your case. So you should be, the most important component is a summary. How good you write a summary is very important. So otherwise, it's okay. We'll ask other faculty here. Professor Shastri is there, T.D. Yadav and Professor Kapoor.
So good morning, sir. TD here. So I think most of the points has been made already, and a description of the case and examination. After examination, also no consideration for the reviewing the first diagnosis was a little bit difficult to accept. And when you are seeing the rectum, there is no sign of inflammation and proctoscopy. Only polyp is seen, and then this patient has 15-16 years history, which is not very classical of inflammatory bowel disease also. And so polyp would have been one of the very strong differential in the beginning. Otherwise, when you said on examination, nourishment was quite good. That is not very usual of ulcerative colitis or Crohn's. And there is no treatment for 15-16 years. That's again very unusual. So all these things would have been pointing more towards the polyp than the inflammatory bowel disease. And then again, choice of surgery, like he said, proctocolectomy, the terminology restorative proctocolectomy. There are multiple things that already everybody has pointed out. So you should, I think, rehearse more than what is being done. Trying to correlate clinical medicine with the investigation is very important. Thank you, sir.
Morning, Pradeep. Good morning. VK Kapoor.
Good morning. Good morning, sir.
So students, there will be cases where there is a long history and now there is a change in the history or there is significant anorexia and weight loss. These are situations where you should think of a underlying benign condition which has undergone a malignant change now. For example, pending achalasia, gastric ulcer, primary sclerosing cholangitis, choledochal cyst, chronic pancreatitis, FAP, inflammatory bowel disease. So you have to keep that in mind. As far as IBD versus polyposis concerned, the history in IBD, especially if you are thinking of ulcerative colitis, is blood, mucus, and pus. If you don't have pus, if you have only blood and mucus, or if you don't have mucus also, if you have only blood, it points more towards FAP. FAP is very unlikely to have all three, blood, mucus, and pus. So your history has to be in great detail. You have to extract this information from the patient. A question was asked from you that what are the risk factors for development of malignancy in ulcerative colitis? You just mentioned one, pancolitis. That is incomplete, grossly incomplete answer. There are so many factors: age at the onset, duration of the disease symptoms. Then comes the pancolitis. Then if a proctoscopy and rectal biopsy has been done, whether there is dysplasia in the rectal biopsy or not, you should always mention that the grading of dysplasia in IBD, especially in ulcerative colitis in the rectal biopsy, has to be validated. If it is classified as moderate or severe, has to be independently verified by two pathologists separately. You never use the word dysplasia associated lesion or mass, DAL, on endoscopy. These are keywords. When you are giving an answer, you have to use the keywords to show your knowledge. You cannot not mention upper GI endoscopy in a patient with FAP. You can't jump straight on to treatment. You have to know that more patients die of periampullary malignancy than of colorectal malignancy in FAP. That is more important. So you have to do that. Even in clinical practice, whenever you see a patient with FAP, you have to do an upper GI endoscopy. whenever you see a young patient with a periampullary malignancy, you have to do a colonoscopy. And we have had both situations where incidentally the other lesion was found. In this particular patient, there is a strong suspicion. You have to have a strong suspicion of malignancy. She had age at onset, I think about 15 or 17 years. She has 15 years duration. And she has recent anorexia and weight loss. Weight loss can be there in IBD, in FAP, in obstruction, but anorexia will not be there. Anorexia is the strong indicator of malignancy. So in such a case, I would like to know who has done the colonoscopy. Do you know the endoscopist? Does he do colonoscopy routinely as a regular practice in IBD, or was it just a routine colonoscopy done by a very busy colonoscopist? He might have missed the lesion. He didn't even look for the lesion. So in a case like this, I would strongly consider getting a repeat colonoscopy done by an expert endoscopist whom I know, who does routinely these screening endoscopies in patients with IBD to look for malignancy, and then multiple biopsies have to be taken. And in a patient with FAP or ulcerative colitis who has an FAP, almost all patients should have surgery because they all, as was pointed out, develop malignancy by 40 years.
100% risk.
But that doesn't mean that you have to wait till 40 years. FAP, once diagnosed, has to be treated. Only thing is that if the patient is young, especially if the patient is female, considering the high incidence of loss of fecundity, these are all words you should have used. You would like not to dissect in the pelvis and do an ileorectal anastomosis, even if there are polyps in rectum, allow her to get married, allow her to complete her family, and then go back and do the anastomosis. And if you are doing a pouch, then the purists, they would not do a double stapled pouch, because in double stapled pouch, you have to leave 1, maybe 2 centimeter of the surgical anal canal above the dentate line, which is the anal transition zone, which also carries the risk of malignancy. So some of the purists, if they are doing a pouch for FAP, they would do a complete rectal mucosectomy, preserve the rectal muscular cuff, do a hand-sewn pure ileal pouch anal anastomosis, which is done at the dentate line. If you are doing a double stapled anastomosis, since you are leaving 1 or 2 centimeter of the anal canal mucosa, again, you have to keep these patients under surveillance. And in selected cases who don't want a pouch, if the rectum is relatively free, if you can clear the rectum of the polyps, if you can keep the patient under regular surveillance, as was pointed out by your examiners, you have an option. Ileorectal is an option of treatment in FAP. And then you don't do the ileorectal at the rectosigmoid junction. You remove the intraperitoneal part of the rectum, and you do the anastomosis at the peritoneal reflection, so that your anastomosis is safe. Your stump is small, which can easily be monitored or surveyed during the follow-up by a simple proctoscopy rather than requiring a sigmoidoscopy or a colonoscopy. So these are some of the points I noted. Students, if you want to read more about FAP, IBD and malignancy, send me a mail, vkkapoor.india@gmail.com. Write UC in the subject of the mail. I'll send you chapters from my books on clinical surgery and operative surgery. Thank you. Thank you, Pradeep.
Thank you, sir. So, Shastri, sir.
Sir is not there.
But Shastri?
So I think he has left a message
left.
for him
Okay.
that his performance is less than satisfactory. Information had to be extracted. History of a condition spanning over 15 years should have concentrated on the natural history, remission and relapses, explaining the outliers as weight loss and melena. Jumping straight to surgery without upper GI endoscopy and other imaging is not acceptable. So this is the message for you, Dr. Ganesh, from Dr. Shastri, sir.
So if there are no more comments, can we wind up, Harjeet, Vaibhav and
Yes.
Sadaf?
Yeah. As the sir has put it very nicely, Kapoor said that these were the follies in the presentation. And I think we have missed a little on genetics because it is extensive, but the message should not go wrong. I understood that the genetic examination is more of screening the subsequent people and the degree of relatives. And for the patient itself, as I said, that if you're not thinking of FAP, or if it is an attenuated disease, or there's some diagnostic dilemma of Lynch, then you should look into those MSH and look for because it will have an implication. MSI will have an implication in further treatment if malignancy is already there. So with that, I think, sir,
Yeah, thank you.
agreeing with every senior member attending, I think the presentation was Dr. Saab has to improve a little more. Thank you very much, sir, for having us.
Thank you.
Thank you.
sir.
Thank you, Harjeet, Sadaf, and Vaibhav, and thank you, Ganesh. Thank you, other faculty as well. Thank you, sir.